Okay, let's unpack this. We've got quite a bit to cover today, diving deep into, well, the ever-evolving landscape of COVID-19. It feels like just when we think we've got a handle on things, the situation shifts again, doesn't it? Our mission today is really to cut through all that noise, take a good look at the very latest data on cases, truly understand these new dominant variants that are making waves, and, crucially, make some practical sense of the changing vaccine guidelines that have been, well, generating so much discussion lately. We're going to be using your provided articles and research to give you, our listener, the most accurate and hopefully actionable insights.
Indeed. And navigating that constant flow of information around COVID-19, it can be pretty overwhelming. What really stands out, I think, from your sources is how they paint this picture of continuous adaptation. We're seeing it from the virus itself, obviously, but also in the public health responses. So we're here to help you not just absorb what is happening, but really understand why it matters to you and how to navigate these complexities in your own life.
Exactly. So whether you're meticulously prepping for a meeting or maybe just catching up on the latest in public health, or perhaps you just have that insatiable curiosity, get ready for some surprising facts, I think, some clear explanations, and hopefully a few aha moments. Let's get started on this deep dive into what you absolutely need to know about COVID-19 right now. Okay, first up, let's talk numbers. When we look at the United States, what does the most recent data tell us about the state of COVID-19 across the nation? Are we seeing like a dramatic surge, or is it more of a slow, persistent hum these days?
Well, the picture is certainly dynamic, and it really requires us to look beyond just the headlines. According to the Centers for Disease Control and Prevention, the CDC, their latest data, this is through the week ending August 16th, it shows that out of nearly 33,000 Americans tested, the exact number was 32,998. 9.9% of those tests came back positive for COVID-19.
Okay, 9.9%, almost 1 in 10.
Exactly. Now, what's really important to note about that figure, that 9.9%, is that it represents an increase. It's up 1.4 percentage points from the previous week.
Ah, okay. So not like a vertical climb, maybe, like we saw earlier in the pandemic?
No, not like those huge waves.
But still, a clear uptick in test positivity that certainly suggests the virus is, well, still actively circulating, doesn't it?
It does.
But beyond just positive tests, what about the severity of these cases? Are people generally experiencing milder symptoms, or are we seeing more individuals needing serious medical attention?
That's always the critical question, isn't it? And the data gives us a bit of a mixed picture there. During that same reporting period, the week ending August 16th, the percentage of cases resulting in death fortunately remained stable. It held at 0.4%.
Okay, that's good news. Same as the week before.
Yes, consistent with the week prior. And that stability in death rates is certainly reassuring. It indicates that for most people who get infected, thankfully, the outcome isn't life-threatening. However, and this is the other side of the coin, we did see a slight but definite increase in emergency room visits.
How much of an increase?
The data shows that 1.2% of cases led to an ER visit. That's an increase of 0.2 percentage points from the previous week.
0.2 points. Small but measurable.
Exactly. So while death rates are holding steady, there's this small but, noticeable rise in people needing urgent, often acute, medical care. It suggests that while COVID-19 might not be as universally severe as it once was, perhaps due to immunity or treatments, it still has the potential to land people in the emergency room.
Right. So if we try to connect this to the bigger picture, it really emphasizes a kind of nuanced reality, doesn't it?
Mhm.
On one hand, the overall volume of COVID-19 reporting has significantly slowed down nationwide. We don't get those daily updates everywhere like we used to.
That's true. The reporting landscape has definitely changed.
But even with that reduced volume, these weekly CDC updates remain absolutely crucial. They're giving us these vital clues. They show the virus is indeed still out there, and for a segment of the population, it's still leading to a point where they need urgent medical attention.
Precisely. And these aren't just abstract statistics, as you said. They represent a real impact on individuals, on families, and on our healthcare system. It serves as a reminder that the virus hasn't simply faded away into the background completely.
So for you, our listener, this really means maintaining a level of informed awareness is still important. Even as the overall public conversation might shift or the headlines get smaller, these metrics offer a grounded, if maybe limited, view of the virus's ongoing activity in the community.
Exactly. And what's interesting here is that this kind of data, these weekly snapshots, they become even more valuable when the broader public health infrastructure maybe isn't focused on daily case counts anymore. The stability in death rates offers a measure of comfort, suggesting that, yes, for the majority, the worst outcomes are less common now. But that increase in test positivity and ER visits indicates the virus continues to cause acute illness that requires medical intervention. It means it remains a significant public health consideration, even if our approach to tracking it has evolved.
That makes a lot of sense. So these weekly snapshots, even if the overall reporting volume is down, are still giving us these vital clues about the virus's trajectory. But are these trends uniform across the country? Or is it pretty evenly spread? Are some areas feeling the impact more than others? Are we seeing distinct hotspots popping up again?
Not at all uniform. And that's actually one of the most striking elements in the data right now. It really highlights the localized nature of health trends, which has been true throughout the pandemic, hasn't it?
Yeah, definitely.
The source material points to specific regions that experience significantly higher percentages of positive COVID-19 tests during that same week, the one ending August 16th. We're talking about a distinct geographical clustering. It's not random.
Okay, so where are these clusters?
Primarily across a swath of western and southern states. Let me list them off. Washington, Oregon, Idaho, California, Nevada, Arizona, New Mexico, Texas, Oklahoma, Arkansas, and Louisiana. Oh, and Alaska, too.
Wow, that's quite a list. It's
Yeah.
almost like a band stretching across the west and south of the country.
It is a noticeable pattern.
So that's a pretty clear geographical clustering. It's not just a random scattering. Like you said, it's
Yeah.
a specific pattern. So the natural question becomes, why these particular regions? What's driving these higher positivity rates in this specific part of the country? Is there like a common thread here that ties these states together?
Well, it's rarely one single factor, is it? It's often a complex interplay, or what we might call a confluence of different elements. This could include things like varied population densities across these states. Some areas have more densely packed urban centers, which can facilitate easier spread, obviously.
Right.
It also probably relates to local public health measures, or maybe the lack of certain measures in terms of community-level precautions, masking policies, vaccine uptake rates. Those can vary a lot state by state, even county by county.
Okay. So local policy plays a role.
Definitely. Then there are just community transmission dynamics. Some regions might have more social gatherings or different patterns of activity that increase contact rates. And of course, variant prevalence, which we'll definitely get into shortly, can play a huge role if a particularly highly transmissible strain gains a foothold in a specific area first.
That makes sense.
Yeah.
Did the sources mention anything else, maybe like travel or tourism?
Yes, actually. One article noted that some specific coastal regions, particularly those with higher seasonal tourism during the summer months, often saw case upticks. And these upticks seem to correlate with increased population movement, suggesting that even without a brand new variant taking over, sheer human mobility can act as a significant amplifier in these areas.
So it's not just about what the virus is doing on its own, but also very much about how human behavior, local policies, and even things like seasonal travel are interacting with it. It truly highlights that even within a national trend, local experiences can differ significantly. So for you, our listener, this means understanding that the national picture might not perfectly reflect what's happening in your specific community or even where you might be traveling. Local conditions are still highly relevant, right? It's worth being aware of the situation in your immediate area or any places you plan to visit, particularly if you happen to be in one of those identified hotspots.
It's a powerful reminder that health trends are often regional, making that local awareness, that local monitoring, still crucial.
Yeah. And this leads us perfectly into the next big question. Which variants are driving these numbers? Because here's where it gets really interesting, partly because the way we even track them is also changing.
Yes, and before we dive into the specific variants themselves, it's really important to understand a significant shift in how this information is even being gathered and reported, especially by official agencies like the CDC. They've actually begun allowing more time to pass between certain types of updates, specifically updates on variant prevalence.
More time between updates. Why is that?
Well, it isn't just a casual change. It seems to be a direct consequence of slowed nationwide reporting from states. As fewer tests are done, or fewer results are reported up the chain.
The data gets patchier.
Exactly. The data stream becomes less consistent. So as a result, the CDC is moving towards using longer timeframes for their model-based projections about variants. And that has implications for how current our understanding truly is at any given moment.
Okay, so the very nature of how we track this evolving virus is changing. This isn't just about the numbers themselves, but about how we get those numbers and how timely they are. What does this shift in reporting methodology actually mean for our understanding of the pandemic,
Yeah.
especially for an informed listener like you who's trying to stay truly up to date?
Well, this shift isn't arbitrary. It's really a pragmatic adaptation to a changing data landscape. As the pandemic evolves, the volume of individual testing and consequently the reporting flowing up from states has decreased significantly compared to, say, a year or two ago.
Right.
So when you have less granular real-time data coming in, the quality of those daily or even weekly snapshots for certain metrics, especially specific variant prevalence, can diminish. It becomes harder to get a clear picture quickly. So to maintain accuracy and provide reliable, robust information, the CDC has to adopt different analytical approaches.
Like using longer time frames for the models.
Exactly. Using longer timeframes for those model-based projections allows them to smooth out some of the inconsistencies that come with sparser data. It gives a more stable, albeit less immediate, picture. It's a trade-off, really. We gain more certainty, perhaps, over a broader period, but we lose some of that immediate day-to-day granularity.
Hmm. So it means that while these projections are still incredibly valuable, they might not always reflect the very latest, most rapid shifts in variant dominance. There might be a bit of a lag.
There might be, yes. That's the inherent challenge with model-based projections when the underlying data stream slows down.
That makes a lot of sense. If the raw data coming in isn't as frequent or robust, then you have to adjust how you analyze it to still get meaningful insights. And this change in reporting methodology, as we'll discuss next, it seems like it makes data from other sources, like wastewater surveillance, even more critical for getting those real-time insights, doesn't it? Because that kind of bypasses the whole individual reporting process entirely and gives us a different kind of snapshot.
Precisely. It completely changes the value proposition for those independent, population-level surveillance methods. When individual testing and reporting become less comprehensive, or maybe have significant lags built in, wastewater surveillance really steps into a more prominent role. It offers an almost unfiltered, population-level signal of viral activity. It's independent of whether individuals are getting tested, whether they're reporting the results, or even if they have symptoms.
Right, because everyone contributes, so to speak.
Exactly. It's about finding alternative ways to keep a pulse on the virus's activity when those traditional methods become maybe less effective for real-time tracking. It's like taking the pulse of the entire community at once.
Okay, so let's talk variants then. It truly feels like a constant game of whack-a-mole trying to keep up. One variant dominates, then boom, another one pops up seemingly out of nowhere. What's the latest on the strains circulating? And how challenging is it to even track them accurately with these new, longer reporting methods? What are the CDC's models telling us, even if they're maybe a bit delayed?
It is indeed a dynamic situation, and tracking these variants has definitely become more complex precisely because of those data reporting shifts we just discussed.
Yeah.
As an example, the latest CDC model-based data that was available when your sources were compiled, this was for the 2 weeks ending June 21st. So already a fair bit in the past by the time we're talking.
Okay, June 21st. Keep that date in mind.
Right. That data indicated that a variant called NB.1.8.1 was the most common at that time. It accounted for about 43% of cases across the U.S.
43%. Okay, so that was the leader back in late June.
Yes. Following that, another variant, a .8.1, was also significant, making up around 31% of cases. And then XFG, which we'll hear more about, was noted at about 14%. So these figures give us a historical snapshot, a picture of what was predominant then. But the fast pace of viral evolution means this picture can change really quickly.
But wait, as you mentioned, that data for the 2 weeks ending June 21st, that's already quite old, isn't it, in terms of the
Right.
rapidly evolving virus, especially when we're talking about this whack-a-mole situation where strains can rise and fall in just a matter of weeks. So for you, our listener, who wants to know what's happening right now, is there a more up-to-date source we can look to? What's truly circulating and predominant today?
Yes, and this really brings to the forefront that difference between those model-based projections and other more immediate data streams. It's a classic example, really, of different data types providing different lenses. It's kind of like looking at a meticulously developed photo album versus watching a live stream.
Ah, I like that analogy. Photo album versus live stream.
Exactly. The model-based projections, they rely heavily on those reported cases from individual testing. And as we discussed, those can have significant reporting lags built in. The reports take time to be collected, processed, analyzed within complex models. So the data you see might reflect a situation from several weeks, maybe even a month or more ago, even if it's the most robust aggregated data available through that method. In contrast, wastewater data, particularly from the CDC's national surveillance system, is often updated much more regularly, sometimes weekly, and it provides a different, often more current picture.
Because it's not waiting for individual tests to be reported.
Precisely. It reflects a viral shedding from an entire community, giving us that unfiltered population level snapshot. It's independent of individual testing habits or reporting delays. It's like taking the pulse of the entire town at once, in near real time.
That's a fantastic analogy, truly illustrating the difference between those two data sets. So if the model data is like looking at a carefully curated photo album, giving us that historical perspective, then the wastewater data is indeed that live stream, much more immediate. So let's look at that live stream data from wastewater. What does it tell us about the truly predominant strain right now? Given its faster updates and ability to bypass individual testing bottlenecks, which variant is currently holding the top spot according to that data?
Okay, building on that live stream analogy, the wastewater data really offers the most current perspective we have on what's circulating right now. The most recent release mentioned in your sources, which accounted for the week ending August 9th, so much closer to our current time than late June.
Right, August 9th. Much better.
That data declared XFG as the newly predominant strain across the nation, and its dominance is really quite striking. This data showed that XFG accounted for a significant 65%, two-thirds of the detected variants in wastewater nationwide.
55%, wow. What about the others we mentioned from the June data, like LP.8.1?
They've faded considerably in comparison. LP.8.1, according to that August 9th wastewater data, accounted for a much smaller 7%. And then two others, LF.7 and XDV.1, each clocked in at about 5%. So XFG is really overshadowing everything else in those recent samples.
Wow, that is a massive shift from the June 21st model data, where XFG was only sitting at 14%.
Yeah.
This really highlights the sheer speed at which these variants can just take over and completely reshape the viral landscape in just a matter of weeks. It's incredible.
It really is.
Let's delve into the specific evolution of these variants a bit, because those numbers are quite telling. You mentioned earlier that NB.1.8.1 had a meteoric rise earlier in the summer. Can you walk us through that specific trajectory again, and then contrast it with XFG's rapid ascendancy?
Absolutely. The rise of NB.1.8.1 was indeed quite remarkable, and it illustrates how quickly these new strains can emerge and spread. It started at effectively 0% of cases back in early April. By the last week of May, it had jumped up to 10%. Then, just a couple of weeks later, at the beginning of June, it was already at 24%, and it soared to that 43% figure by the end of June, making it the predominant variant in the model-based data for that period. That's an incredibly rapid expansion over just a 2-month window. It clearly demonstrated its competitive advantage against whatever variants were circulating at that time.
A really fast takeover. And then XFG, which we now know is the overwhelming dominant strain according to the latest wastewater data. It also had a similar sharp climb to power, maybe even faster. And it's described in the sources as a recombination of two other variants, LF.7 and LP.8.1.2. Can you explain a bit more about what recombination means in this context? How did XFG manage to make its way to such widespread dominance so quickly? What genetic tricks did it pull, so to speak?
That's a great question, and understanding recombination is really key to XFG's story. Think of it like this. If two different virus strains happen to infect the very same human cell at the exact same time,
Which can happen.
it can happen. When they're replicating inside that cell, they can sometimes essentially swap pieces of their genetic material. It's like they're sharing and remixing their instruction manuals. This process creates a brand new hybrid strain that inherits genetic traits from both of its parent viruses.
So it's like picking the best bits from both parents.
Potentially, yes. In the case of XFG being a recombination of LF.7 and LP.8.1.2, it essentially seems to have borrowed advantageous traits from both. This could give it an edge, perhaps in transmissibility, maybe in immune evasion, or some combination.
Okay, so how did its rise compare to NB.1.8.1?
Well, XFG's trajectory mirrors NB.1.8.1's rapid ascent, but maybe even more dramatically towards the end. It was practically undetectable, really at 0% of U.S. cases through March. By early June, it had started to emerge, reaching about 11% in the model data, and then up to 14% by late June. But then, as we saw with that August 9th wastewater data, it underwent a truly explosive jump, hitting that 65% dominance.
From 14% in late June models to 65% in early August wastewater. That's incredibly fast.
It is. What's really striking here is that rapid ascendancy, moving from a minority share in June to a clear, significant majority in August, according to the most current data stream. This strongly suggests it has either exceptionally high transmissibility, meaning it spreads much more easily from person to person, or perhaps superior immune evasion.
Meaning it can get around the immunity we've built up.
Exactly. It might be better at bypassing some of the immunity we've developed from previous infections or vaccinations, or perhaps it's a combination of both factors. It's effectively outcompeting all other strains so quickly because it appears to be genetically more fit in the current human population environment.
So it's like the virus is constantly remixing itself, trying out new combinations, and XFG found the perfect mix, the current chart topper, if you will, to become the dominant strain. It really underscores the importance of those wastewater readings, doesn't it? Giving us that more immediate, unfiltered sense of what's truly circulating in our communities, bypassing the slower reporting of individual tests.
It does.
So, for you, our listener, understanding the dominant variant helps contextualize the potential for spread in your area. While the official health agencies note that symptoms may not differ significantly across variants, we'll get to that a new dominant variant often signals a potential new wave of infections, simply because it's better at spreading or evading previous immunity, making it more likely you might encounter it.
It's a crucial point for personal awareness, absolutely. While we don't necessarily need to panic every time a new variant emerges, knowing that a highly transmissible or immune-evasive variant like XFG is dominant allows you to make informed choices about your own precautions, whether that's considering masking in crowded indoor spaces again, or just being more vigilant about symptoms if they pop up. These rapid shifts really highlight why continuous monitoring, even with less conventional methods like wastewater surveillance, is so vital for public health in this ongoing pandemic phase.
Those numbers really do show just how quickly the landscape can change. It underscores the value of those wastewater readings. Okay, now let's shift gears to something that's been generating a lot of discussion and honestly, quite a bit of controversy: the vaccine guidelines. This section has seen some truly significant shifts recently, creating, well, a landscape of divergence, hasn't it? And it's left many people wondering what the current recommendations truly are, especially comparing the federal level versus what other major medical bodies are saying. What's the latest on who should get vaccinated, particularly given these recent federal level changes?
This has indeed been one of the most complex and frankly confusing areas for many people trying to stay informed lately. On May 27th, we saw a truly significant development. It marked a notable departure from previous norms in how these recommendations are usually handled. On that date, HHS Secretary Robert F. Kennedy Jr. stated that the COVID-19 vaccine would no longer be included in the CDC's recommended immunization schedule for two specific groups: healthy children and pregnant women.
Okay, removing it from the recommended schedule for healthy kids and pregnant women, that sounds like a big change.
It was, and it was a notable move because, according to your source material, it significantly bypassed the normal, established scientific review process that vaccine recommendations typically undergo. You know, the advisory committees, the public comment periods.
Right, there's usually a whole process involved.
Exactly. And it also broke quite sharply with previous expert guidance that had come from a wide range of medical and public health organizations over the preceding years.
That sounds like a pretty significant departure from how these public health recommendations are typically made. The idea of bypassing the normal scientific review process and breaking with previous expert guidance immediately raises questions, doesn't it? So what were the practical implications of that federal shift? Who would still be recommended for COVID-19 vaccines under these new, narrower federal guidelines? And what concerns did experts raise about this change right away?
Right. So under these new, more restricted federal guidelines announced by Secretary Kennedy, the recommendation for COVID-19 vaccines would primarily be narrowed to just two specific groups. Those are individuals over 65 years of age and people with existing health problems or immunocompromised conditions.
So basically older adults and those with underlying health issues.
That's the gist of the narrowed federal recommendation, yes.
Right.
This significantly reduced the scope of who was federally recommended to receive the vaccine compared to previous guidance. And crucially, the sources highlight that medical experts immediately warned that this shift could have substantial practical consequences. They worried it could potentially make it much harder for people outside those two specific groups who might still want the COVID-19 vaccine to actually get it.
How would it make it harder? Access issues? Insurance?
Potentially both. Concerns were raised about creating significant access barriers. If it's not on the official recommended schedule for certain groups, that could impact things like insurance coverage or even just the simple availability of the vaccine in local pharmacies or clinics for those groups.
Hmm. This raises a very important question, especially for you, our listener, who follows public health policy closely. What are the broader implications of such a change, particularly when it's reported to have bypassed the established scientific review processes? The source material highlights that such a move can not only create those practical access barriers, even for those who wish to be vaccinated, but it can also sow significant confusion among the public. And critically, it runs the risk of eroding trust in public health recommendations overall. When the usual rigorous, transparent scientific process isn't followed, it naturally invites scrutiny and uncertainty, leaving people unsure which advice to follow.
Precisely. And as your guides on this deep dive, it's absolutely crucial for us to maintain strict impartiality here. We need to be very clear. We are simply reporting on the content provided in the source material. That material indicates this notable break from previous expert guidance and a bypassing of the normal scientific review process by Secretary Kennedy Jr. We are not endorsing any specific viewpoint or policy. We're just clarifying the information presented regarding this federal shift, its reported implications, and the concerns it raised within the medical community, as described in the articles you provided. It's about presenting the facts of the situation as reported.
That's a really important distinction, thank you. And it helps explain why leading professional medical organizations across the country have felt compelled to step in with their own guidance, right?
Hmm.
Because if the federal guidance is perceived by them as diverging from an established scientific consensus, other groups with deep medical expertise and a direct connection to patient care would naturally feel a responsibility. A responsibility to offer their own evidence-based recommendations to their specific patient populations, almost like a check and balance.
Exactly. Given this federal shift, it was almost inevitable, perhaps, that state health departments and very notably national professional organizations would feel a responsibility to weigh in and provide clarity. Clarity based on their own scientific assessments and expertise. Groups like the American Medical Association, the AMA, the American Academy of Pediatrics, the AAP, and the American College of Obstetricians and Gynecologists, ACOG.
So the big ones for doctors, pediatricians, and OBGYNs.
Yes, the leading professional bodies. They have notably broken from the more restrictive federal guidance issued by Secretary Kennedy and HHS. These organizations, which really represent the collective expertise of doctors directly caring for these specific populations, they are continuing to suggest the COVID-19 vaccine for pregnant women and for children. And they're doing so based on their assessments of the scientific evidence regarding safety, efficacy, and on the specific needs of these potentially vulnerable populations. They are essentially upholding what they consider to be evidence-based best practices for their patients.
So these are the leading medical bodies for children and pregnant women, specifically advising something different than the federal government's latest stance. That's a significant divergence, no doubt about it. Can you give us a more detailed look at what, say, the American Academy of Pediatrics, the AAP, is recommending specifically? Their guidance must be pretty detailed and carefully considered for their target demographic of children?
Yes, the AAP's guidance, for instance, is indeed quite clear, specific, and it's tailored to different pediatric age groups. It reflects a detailed risk-benefit analysis from their perspective. They recommend that all children between 6 months and 23 months of age, so the very youngest group, receive the latest COVID-19 vaccine.
All kids under 2.
That's their recommendation, yes. And the primary rationale stated is to significantly reduce the chance of serious illness in this very young, vulnerable age group where the immune system is still developing and outcomes can sometimes be less predictable. Furthermore, for older children and adolescents, those aged 2 to 18 years, who may not have other high-risk factors like immunosuppression.
So generally healthy older kids and teens.
Right. The AAP advises that they can receive and should be offered the vaccine if they were not previously immunized. This highlights the AAP's belief in the broader benefit of vaccination across pediatric age groups, aiming to provide protection against severe outcomes from COVID-19, even if a healthy child's baseline risk is generally lower than, say, an elderly individual's. Their detailed recommendations reflect their careful consideration of the available scientific data as they interpret it.
What's truly fascinating here, and perhaps a bit unprecedented in recent public health history, is seeing this role of professional organizations stepping up so clearly, providing specific guidance when federal recommendations appear to diverge from what they see as the broader scientific consensus. They're essentially reinforcing what they view as evidence-based best practices for their patient populations, children, pregnant women, to mitigate serious illness. It really speaks to that broader concept of expert consensus in medicine, doesn't it? Where the collective wisdom and research of specialized bodies aim to inform the best possible care, even when federal directives
It
shift.
absolutely does.
The AAP's detailed recommendations for specific age groups reflect that careful consideration of risk and benefit for these populations, aiming to reduce serious illness. And it really contrasts sharply with the more limited federal guidance we discussed. It feels like a critical safety net, in a way, for medical advice.
It absolutely is. And this mechanism in public health is vital historically. When there's a perceived vacuum or perhaps a significant shift away from what the established scientific community broadly supports based on cumulative evidence, these professional organizations often step in. They aim to provide continuity, clarity, and recommendations based on their deep expertise and understanding of specific patient needs, drawing from the vast body of medical research available. Their goal is usually to ensure that patients and their families receive advice that is consistent with the latest scientific understanding, irrespective of broader political or policy shifts occurring at the federal level.
Okay, so we have federal guidance moving one way, restricting recommendations, and leading medical organizations moving another way, maintaining broader recommendations, seemingly based on different interpretations of the scientific consensus or perhaps different processes. That definitely leaves a lot of people in a quandary, doesn't it? Especially parents trying to make informed health decisions for their children. It sounds confusing. What does this mean for the everyday person trying to make a decision about vaccination for themselves or their children? What's the official word from the CDC itself on how to navigate this divergence, given the conflicting advice floating around?
This is where the landscape becomes even more personalized, and it really places a greater onus on the individual patient or parent. In light of this diverging advice, the updated CDC guidelines themselves, as reported in your sources, actually sort of step back. They refrain from making those broad, blanket recommendations for these contested groups. Instead, the CDC now specifically suggests that parents consult directly with their child's pediatrician on a case-by-case basis.
So the CDC isn't picking a side, essentially. They're saying, talk to your doctor.
That seems to be the approach, yes. It represents a significant shift from a more centralized, unified public health recommendation model to a highly individualized approach. It effectively delegates the decision-making process down to the private consultation between the patient or the parent and their doctor.
Okay. This raises a very important question then for you, our listener, who's trying to navigate this complex health landscape.
Yeah.
What does it truly mean when the CDC refrains from making recommendations and instead points you towards individual consultation? It essentially places the responsibility, the onus, directly on you, the individual, to engage proactively with your healthcare provider. Now, while this approach certainly empowers personalized care, it allows for your specific health history, your current circumstances, individual risk factors to be properly considered.
Which is valuable.
Absolutely valuable, but it also fundamentally shifts the burden, doesn't it? It moves the responsibility away from clear, unified public health guidance towards individual medical advice. And that can be challenging for some people to navigate, especially if they don't have easy access to a trusted provider or if they're feeling overwhelmed by conflicting information. It demands more active participation from the individual.
It absolutely moves the conversation from being primarily a public health campaign issue to being a private medical decision, emphasizing that unique doctor-patient relationship. For you, this means your pediatrician or your primary care physician becomes an even more critical source of information than perhaps ever before on this topic. They are uniquely positioned to weigh your specific circumstances, your family's health history, maybe the local prevalence of variants in your community, against the varying guidelines coming from different organizations. They are now, effectively, the primary navigators of this complex, sometimes contradictory landscape for individual families and patients. It truly underscores the importance of having a trusted medical advisor in your corner that you can talk these things through with.
It really underscores the importance of having that direct, open conversation with your doctor, asking specific questions, voicing your concerns, and getting advice tailored specifically to your unique situation. This is clearly not a one-size-fits-all moment in public health regarding these vaccines, and that direct communication becomes paramount. Okay. Now, regardless of vaccination status or the specific variant circulating like XFG, what are the common symptoms we should all be looking out for right now? I've heard anecdotal reports, you see them online, about new or maybe more severe symptoms with recent variants, like something people were calling razor blade throat for a while there. Is there any official confirmation of these types of unique symptoms that might indicate a specific variant is involved?
That's a very common question, and it really speaks to the public's understandable desire for specific, actionable information, doesn't it? Especially when new variants emerge and cause anxiety. What's actually quite consistent, though, and in a way maybe even fascinating from a scientific standpoint, is the consistency of the core symptom list despite all these variant changes we've seen. While anecdotes like razor blade throat or other specific descriptions of discomfort might circulate widely on social media or in personal conversations,
And they do spread fast.
they do. But official health agencies, including both the CDC and the World Health Organization, officially note that there is currently no strong evidence suggesting that specific symptoms are unique to different COVID-19 strains. The virus's general presentation and the range of common symptoms remain largely consistent, regardless of which variant is currently predominant in the population. So, while a particular infection or variant might feel different to an individual based on their own body and immune response, the overall symptom profile recognized by health agencies hasn't fundamentally changed.
That's a really crucial clarification. So, despite what you might hear online or from friends about, oh, this new variant causes this weird symptom, the official agencies are saying the same general list of symptoms applies, regardless of the variant currently circulating. So for our listener who needs to be well informed, can you remind us of that official list from the CDC? Just so we're all clear on what to look for. It's easy to forget the full breadth of them sometimes.
Absolutely. It's always a good practice to revisit this list periodically, I think. The CDC outlines a pretty comprehensive range of common COVID-19 symptoms. These include fever or chills, a persistent cough, shortness of breath or difficulty breathing, a sore throat, congestion or a runny nose. Also, a new loss of taste or smell that one is still on the list. Fatigue that feels more profound than usual tiredness, muscle or body aches, headache, and sometimes nausea or vomiting.
Okay, that's quite a range.
It is. And it means that if you experience any of these common symptoms, whether it's a new, persistent cough that just won't go away, or a sudden onset of fatigue that truly knocks you out, it's wise to consider COVID-19 as a possibility. Taking precautions like testing if possible, staying home, or avoiding close contact with others, especially vulnerable individuals, remains the prudent approach when these symptoms appear.
That's a comprehensive list, and it's a good reminder that many of these symptoms can overlap significantly with other common seasonal illnesses, like the flu, or even just a bad cold, which makes it challenging sometimes to differentiate without a test, doesn't it?
It certainly does. Symptom overlap is a major challenge.
So even though the overall symptom profile remains consistent across variants, what do we need to know about distinguishing between milder symptoms that can likely be managed at home and those critical warning signs, ones that mean you need to seek immediate medical attention? When do these symptoms cross that crucial line from uncomfortable but manageable to needs urgent professional medical care?
This is perhaps one of the most critical pieces of information for you, our listener, to know and remember, because recognizing these specific red flags quickly can literally be life-saving. The CDC clearly advises seeking medical care immediately, and that means don't wait for your doctor's office to open. Consider going to an emergency room or calling emergency services if you or someone you know experiences any of the following symptoms. These are the urgent indicators, irrespective of the variant or your general health status.
Okay, what are they? Let's be very clear.
Firstly, any significant trouble breathing or noticeable shortness of breath, that's always number one. Secondly, persistent pain or pressure in the chest, especially if it feels new or seems to be worsening. Thirdly, any new confusion or a significant change in mental state or alertness. Fourthly, an inability to wake up or stay awake. That indicates a severe energy depletion or potentially a neurological issue. And critically, if you notice that your lips, your nail beds, or your skin, and this can vary depending on your natural skin tone, appear pale, gray, or bluish, that's a sign of critically low oxygen levels called cyanosis.
Okay, those are clearly very serious indicators, far beyond just feeling unwell or having a bad cough. What's the deeper significance of recognizing these particular symptoms quickly? Why are these specifically called out for immediate, urgent attention, rather than just, say, monitoring at home or calling your regular doctor later?
This raises an important question for you, our listener. Are you truly deeply aware of these critical warning signs? Have you discussed them with your family members so everyone knows what to look for? These are not just symptoms of discomfort. They are powerful physiological indicators of potentially severe, potentially life-threatening disease processes occurring in the body. They suggest that the body's most vital functions, particularly the oxygenation of your blood and your neurological status, are being dangerously compromised.
So time is really critical.
Time is absolutely critical. The reason for immediate attention is simple. Early medical intervention can make a profound, life-saving difference in outcomes for serious complications like severe pneumonia, dangerous blood clots, or organ damage that COVID can sometimes trigger. Recognizing these signs early could genuinely be the difference between a successful recovery and a much more dire scenario. They are absolutely not to be taken lightly or ignored.
So for you, our listener, this means having a clear plan in your mind, or even discussed with your household, about when to escalate, when to move from monitoring symptoms at home to seeking professional emergency help. These specific symptoms we just listed, trouble breathing, chest pain, confusion, inability to stay awake, pale or blue skin lips, these are the unmistakable red flags that should prompt immediate medical contact. Often that means a trip to the emergency room, not just waiting to call your general practitioner's office during business hours.
That's exactly right.
Knowing them and discussing them with your household members can empower you to make those critical decisions for your own health or the health of your loved ones in a timely, decisive manner. It's really about being prepared for the most serious possibilities, even if they remain relatively rare.
Absolutely. Knowing those critical indicators is paramount for everyone. Being prepared to act quickly if any of these signs appear is a vital part of navigating the ongoing presence of COVID-19 and truly understanding what staying informed means in the most practical, potentially life-saving sense.
Ooh. Okay, that was a truly comprehensive look at where we stand with COVID-19 right now. We've gone all the way from dissecting the latest positivity rates and understanding those regional hotspots, to tracking the meteoric rise of variants like XFG with the help of that crucial wastewater data giving us the real-time scoop. And finally, unpacking the really nuanced and sometimes conflicting advice surrounding vaccinations, comparing the federal agency shifts versus the guidance from leading medical organizations.
We covered a lot of ground.
We did. It's clear that while the headlines might be less frequent these days, maybe smaller font, the virus is still actively evolving. And understanding these shifts, the data, the variants, the guidelines, is absolutely key to staying well-informed and making sound decisions for yourself.
Indeed. And if we connect all of this back to the bigger picture, it really highlights this continuous dynamic interplay, doesn't it? Between the virus evolving, the public health responses adapting, sometimes smoothly, sometimes maybe less so, and ultimately individual decision-making. The information we've discussed today really underscores that staying truly informed in this environment means looking at multiple data points. You need the case rates, yes, but also those crucial insights from wastewater surveillance. And then critically, engaging with trusted medical advice, having those conversations with your doctor, especially when making personal health choices like vaccination. This multifaceted, nuanced approach is absolutely essential in a world where health information can be overwhelming and sometimes, as we've clearly seen today, even contradictory.
So what does this all mean for you, listening right now? We sincerely hope this deep dive has not only given you a clearer picture of the current situation, but also a solid, actionable foundation for understanding the landscape, hopefully empowering you to make the most informed choices for your health and the health of those around you.
And perhaps for a final provocative thought to leave you with. Given this continuous evolution of variants like XFG and the diverse, sometimes diverging approaches we see in public health guidelines, and this increasing reliance on individual medical consultation, how might you approach gathering and evaluating health information in your daily life moving forward? How do you personally cut through the noise, discern reliable sources for misinformation, and ensure you're making the most informed decisions for yourself and your loved ones? What does being truly informed look like for you, and how do we all cultivate that critical thinking in such a complex and rapidly changing environment?
A perfect thought to leave you with. It's a challenge we all face in this modern information age, isn't it? Thank you so much for joining us on this deep dive today. We'll be back soon with another stack of sources and another fascinating topic to unpack for you.